3 surgeons were already scrubbed in when I stepped between the doors and the gurney. I did not say a word for the first 10 seconds. I just stood there, arms out, blocking the only way into that operating room. Someone behind me said I had lost my mind. Someone else went to call security. I heard the radio crackle before I even turned around. And still, I did not move. 19 days on that floor, and I was about to lose all of it over something I could not yet put into words. I just knew, standing there, that if that patient went through those doors, he was not coming back out the way everyone expected. Before I keep going, I want to say something to whoever is watching this. If you have ever noticed something nobody else could see and had to decide whether it was worth losing everything to say something about it, this channel is for you. I put up a story like this every week about ordinary people who paid a real price for trusting what they knew before anyone else believed them. If that sounds like you, hit subscribe. It genuinely helps more than you would think. Okay, let me take you back to the beginning of that shift. My name is Lauren Castillo, and at the time all of this happened, I was a 19-day-old nurse on the surgical floor at Trinity Memorial Hospital. Not 19 days a nurse in general. 19 days on that particular unit, in that particular building, still learning where the extra blankets were kept and which vending machine ate your money without giving anything back. Before Trinity, I had spent 2 years on a general medical floor across town, so I was not brand new to nursing itself. But surgical was different. The pace was different. The stakes felt closer to the surface because everything that happened here was about to happen on purpose, under a blade, with a person lying still and trusting that every single detail had been checked twice. The patient I want to tell you about was a man named Walter Higgins. He was 68 years old, retired from 31 years driving a delivery route for the same company, and he was at Trinity for what should have been one of the more routine procedures on the schedule that day, a total knee replacement on his right side. He had been in pain for years, the kind of pain that turns a simple walk to the mailbox into a calculated decision, and he was, by every account I heard that morning, thrilled to finally be getting it fixed. He told me twice before 9 in the morning that he was going to walk his granddaughter down the aisle in June without a cane, and both times his eyes went a little wet saying it. I picked up his case at the start of my shift when the night nurse handed off report to me in the hallway outside his room. She told me he had slept fine, vitals had been stable overnight, nothing flagged, nothing pending, straightforward pre-op checklists left to finish before he went down. I remember thinking, walking into his room with my clipboard, that this was going to be one of the easy ones. A patient who was healthy for his age, motivated, in good spirits, with a procedure that our surgical team performed several times a week without complication. I had no reason to expect anything else. The first thing I did, the way I always do with every patient before a scheduled procedure, was a full set of baseline vitals: blood pressure, pulse, oxygen level, temperature, the whole routine you do almost without thinking after you have done it 1,000 times. I put the cuff on his left arm first because that is simply the arm closer to the doorway in that particular room, and I got a reading of 138/84. Completely unremarkable for a man his age on the morning of a procedure. A little elevated maybe from nerves, but nothing that would raise an eyebrow on any chart in the building. Then, because our unit had just started using a new pre-op protocol that required a comparison reading on the opposite arm to catch equipment error, I moved the cuff to his right arm and took the pressure again. And that is where the first small thread appeared, the one I would spend the rest of the day pulling on whether anyone wanted me to or not. The reading on his right arm came back at 106/62. A gap like that, more than 20 points systolic between the two arms, is not something you are supposed to just write down and move on from. I remember standing there for a second, with the cuff still half inflated, wondering if I had made a mistake. So I did what any careful nurse would do. I checked the machine on a different patient down the hall to make sure it was calibrated correctly, and it was fine. I came back and took Walter's blood pressure a third time, alternating arms again, slower this time, making absolutely sure the cuff was positioned the same way on both sides. The left arm came back close to the first reading. The right arm came back low again, and this time I also noticed something I had not paid attention to on the first pass, that the pulse in his right wrist felt fainter under my fingers than the pulse in his left, thinner somehow, like pressing on a garden hose with the water barely trickling through it compared to one running at full pressure. I asked him if he had any pain anywhere besides his knee. He said his lower back had been a little sore that morning, but he chalked it up to the hospital bed, said it was nothing like the beds at home, and laughed about it. I asked if the soreness had come on suddenly or built up slowly, and he said honestly he could not remember, because he had been so focused on the knee for so many months that everything else in his body had become background noise to him. I want to be clear about something here, because I think it matters for the rest of this story. At that point, I did not know what was wrong. I had no diagnosis in my head, no dramatic realization, nothing I could have written on a chart that any doctor would have accepted as a reason to stop a scheduled surgery. All I had was a blood pressure discrepancy between two arms, a faint pulse on one side, and a man with unexplained back pain who was about to be put under general anesthesia for an unrelated procedure. Any nurse with my level of experience would tell you that combination sits somewhere between mildly odd and genuinely reportable. But knowing something is odd and knowing what it means are two very different things, and I only had the first one. Still, something about it would not let me go. I have thought about this a lot since, about why that particular morning, with that particular set of numbers, lodged itself in me the way it did, instead of sliding past like 100 small oddities do every week on a busy floor. I think it was the pulse. Numbers on a screen are numbers on a screen, but feeling that difference under my own fingers, one side strong and one side thin, made it feel less like a statistic and more like a fact about a living person sitting 3 feet away from me, smiling, talking about his granddaughter's wedding. I documented everything precisely the way I had been trained. Both sets of readings, the pulse difference, his comment about the back soreness, and I flagged it for the resident doing rounds that morning. His name was Dr. Patel, a careful, well-regarded second-year resident who I had worked with several times already and genuinely respected. He came in, checked Walter himself, felt both pulses, looked at the numbers I had written down, and considered it seriously. That is important to say, because he did not brush past it. He ordered a repeat set of vitals in 20 minutes and said if the discrepancy persisted, he would loop in anesthesia before Walter went down. 20 minutes later, the discrepancy was smaller, not gone, but smaller, 12 points instead of over 20, and the pulse felt closer to even on both sides. Dr. Patel reviewed it, noted that blood pressure differences of that size are common enough in older patients due to 100 benign reasons: positioning, cuff size, arterial stiffening that comes naturally with age, and told me he did not see anything that justified delaying a surgery Walter had been waiting months for. He was not dismissive. He explained his reasoning to me directly, walked me through why an isolated and narrowing discrepancy with no other red flags on the chart, no chest pain, no distress, normal preliminary blood work, did not clear the bar for canceling a case. Every part of what he said made sense. If I had been standing in his position, with his training and his years of seeing exactly this pattern resolve into nothing 100 times before, I believe I would have made the same call. But I could not shake the feeling in my chest that something underneath all of that reasonable logic was still sitting there unresolved. I kept coming back to Walter's face when I asked about his back, the half-second of genuine confusion before he laughed it off, and I kept coming back to that pulse under my fingers, the way one side had felt thin in a way that ordinary aging does not usually feel, at least not in my limited experience. 20 minutes passed, then 30. Walter was moved onto the transport gurney, cheerful, joking with the orderly about how he hoped the anesthesia would not make him say anything embarrassing on the way out. I walked alongside the gurney toward the double doors of the operating suite, my clipboard still in my hand, trying to tell myself that Dr. Patel was right, that I was a 19-day nurse on this floor, reading too much into 2 blood pressure cuffs and a passing comment about a sore back. And then, 12 feet from the doors, Walter shifted his weight slightly on the gurney to get more comfortable, let out a small, sharp breath through his teeth, and pressed his hand flat against the center of his lower back for just a second before letting it drop again, like it was nothing, like it was the bed again, like it was nerves. That was when I stopped walking. I stopped walking, and for a moment nobody around me noticed, because a gurney rolling 6 inches slower than usual does not look like anything at all. Then, the orderly pushing from the head of the bed felt the resistance and looked back at me, confused, and asked if something was wrong with the wheels. I said I needed 1 more minute before Walter went through those doors. He looked at me like I had spoken a foreign language, because in a surgical unit, 1 more minute before a scheduled case is not really a small request. Every minute has been accounted for since 6 in the morning. Every room, every set of hands, every piece of equipment is on a clock that other patients are also depending on. I asked Walter directly, right there in the hallway, to describe the pain in his back 1 more time. Not the general soreness he had mentioned before, but this specific moment, this specific wince. He hesitated, and I watched him do the thing patients do sometimes, where they downplay something because they do not want to be the difficult one, the person who slows everything down on the day they have been waiting for. He said it was probably just the angle he was lying at, that it came and went, nothing sharp, more like a deep ache that occasionally spiked. I asked him to point to exactly where it was, and he moved his hand to a spot just left of his spine, roughly at the level of his lower ribs, and pressed 2 fingers into it. I placed my own hand gently over that same spot, mostly to check for tenderness, and what I found was not tenderness in the way I expected. There was a very faint pulsing quality under my fingers, subtle, easy to miss if you were not already looking for something, but distinct once I focused on it. Not the steady, even beat you feel, checking a wrist or a neck. Something with a strange quality to it, wider somehow, less crisp. I want to be honest that in that moment, I still did not have a name for what I was feeling. I was not thinking the word that I would eventually think. Hours later, when everything became clear, I was thinking, this is not nothing, and I do not have the authority to make that decision by myself, and I am almost out of time to do anything about it. The head nurse on our unit, a woman named Carol Jennings, who had been at Trinity for over 20 years, happened to be walking past at that exact moment, and I asked her, probably too loudly, to come look at something before the patient went into the operating room. Carol was not someone who indulged nervous new hires. She had trained enough nurses to develop a very fast internal filter for who was overreacting to normal hospital chaos, and who might actually be seeing something real, and to her credit, She did not immediately wave me off. She came over, checked what I had checked, felt the same faint pulsing under her own fingers, and her face changed slightly, not into alarm, but into the focused blankness of someone recalculating. Even so, Carol was careful in exactly the way Dr. Patel had been careful. She said the finding was worth noting, but was not, on its own, a clear reason to stop a scheduled procedure that had already been cleared twice that morning by the responsible physician. She said she would page the attending surgeon directly and let him make the final call, because that decision was above both of our pay grades, and she meant that respectfully, not dismissively. She was not protecting a schedule out of laziness. She was following the actual structure of how decisions like this are supposed to be made in a hospital, where a nurse raises a concern, a physician evaluates it, and the person with the most training and the most legal responsibility decides what happens next. That structure exists for good reasons. It exists because if every hunch from every staff member halted every procedure, no hospital could function, and plenty of patients would suffer real harm from delayed care. I understood that then, and I understand it even more now. The attending surgeon on Walter's case was Dr. Marcus Webb, a man who had been performing joint replacements for over 20 years and had, by reputation, one of the steadiest hands and calmest temperaments in the department. He came out to the hallway within a few minutes, already gowned, clearly pulled directly from final preparations in the operating room. I explained what I had found, the blood pressure discrepancy that morning, the pulse difference, the back pain Walter had mentioned twice now, and the strange, pulsing sensation I had just felt near his spine. Dr. Webb listened to all of it without interrupting, which I appreciated, and then he examined the area himself, pressing gently, asking Walter a few quick questions about the pain, its onset, whether it radiated anywhere. His conclusion, when it came, was calm and confident. He said that in a man of Walter's age and build, a faint pulsation near the abdominal aorta was not automatically abnormal, particularly in a thinner patient, and that isolated findings like this, without other supporting evidence, such as severe pain, dropping blood pressure, or signs of shock, were common enough that stopping every case over them would be medically unjustifiable. He pointed out fairly that Walter's vitals had actually stabilized somewhat since the earlier readings, that his color was good, that he was alert, comfortable, and joking with staff only minutes earlier. He said that if he canceled every knee replacement on a patient over 60 with a mild blood pressure variance and some lower back discomfort, he would be canceling a significant portion of his schedule for reasons that almost never turn out to be serious. I remember him saying, not unkindly, that in 22 years of practice he had seen this exact conversation happen a dozen times, and it had amounted to something serious perhaps once, maybe twice, and both of those times there had been additional red flags present that were simply not present here. He was not wrong to reason that way. That is what experience is supposed to do. Weigh a new situation against the pattern of everything that came before it, and most of the time, that pattern holds. I could see, watching his face, that he was doing real medical thinking, not brushing me off to save time. He even said, before turning to head back toward the operating room, that he appreciated nurses who paid close attention, because it was that kind of attention that occasionally did catch something important, just not, in his professional judgment, this time. That should have been the end of it. 2 physicians and 1 senior nurse had all evaluated the same information I had and reached the same reasonable conclusion. I had done my job. I had raised the concern through the proper channel to the proper person, and the proper person had made his decision using more training and more experience than I had. anyone watching from outside would have said I had nothing left to do but step back and let the professionals proceed. But I did not step back. I do not fully know how to explain, even now, what kept my feet planted in that hallway, instead of moving aside the way I should have. Part of it was the specific quality of that pulsing under my fingers, a texture I could not stop replaying in my mind, wider and less orderly than a normal heartbeat. Part of it was the location, directly along the path of the largest blood vessel in the human body, a detail I kept circling back to from a lecture years earlier in nursing school that I had not thought about in a long time until that exact moment. And part of it, if I am honest, was simply Walter's face when he pressed his hand against his back and tried to laugh it off. The specific effort in that laugh, like a man trying to make sure nobody worried about him on what was supposed to be a good day. Dr. Webb turned to walk back through the double doors, and the orderly began pushing the gurney forward again, and Carol put her hand lightly on my shoulder in a gesture that was meant to guide me out of the way. And instead of moving, I stepped directly in front of the gurney, put my arms out on either side of the doorframe, and told them, as steadily as I could manage, that I did not think Walter should go through those doors yet. The hallway went very quiet for a moment, and then it did not stay quiet at all. Dr. Webb stopped walking and turned back around slowly, and I watched something shift in his expression, not anger exactly, more like disbelief mixed with the beginning of real irritation. He asked me, in a tone that was still controlled but noticeably firmer than before, if I understood what I was doing. I said I did. He said that he had heard my concern, evaluated it with the head nurse present, and made a clinical decision, and that a nurse physically blocking a scheduled surgery after that decision had been made was not a gray area. It was a serious breach of protocol that could have real consequences for me. Carol, standing just behind him, was not defending me anymore. She looked genuinely alarmed now, not about Walter, but about what I was doing to my own position. She said my name quietly, the way you say someone's name when you are trying to give them one last, quiet chance to step back before something becomes unfixable. I understood exactly what she was offering me. I could still, in that moment, apologize, say I had overreacted, step aside, and this would become a story about a nervous new nurse who got a little too worked up on a slow morning. Nobody would have held it against me forever. It would have been forgotten in a month. I did not move. One of the other surgeons, Dr. Reyes, who had been scrubbed in and waiting inside the room, pushed through the doors to see what was causing the delay, still in his surgical gown, mask hanging loose around his neck. He was told quickly what was happening, and I watched him process it with the same measured skepticism as everyone else. He asked me directly, not unkindly, what exactly I thought was wrong with the patient, because if I was going to physically prevent a surgery from happening, I needed to be able to say clearly what I believed the danger was, not simply that something felt off to me. I told him what I had told Dr. Webb, the pulsing sensation, its location, the back pain, and I said, as plainly as I could manage with my heart hammering in my chest, that I thought there could be something happening with the large vessel near his spine, something that surgery and general anesthesia could make significantly worse rather than better. I want to pause here and say something directly to you, because this is usually around the moment in these stories where the tension gets hard to sit with. If you have ever been in a situation like this, not necessarily in a hospital, but any moment where you were completely convinced of something important and everyone around you, reasonably, was not, I would really like to hear about it in the comments. What did you do? Did you speak up anyway, or did you let it go? I read every single one of these, and honestly, they are a huge part of why I keep making these videos every week. Okay, back to that hallway, because it was about to get a lot worse before it got better. Dr. Reyes exchanged a look with Dr. Webb, the kind of look colleagues share when they are quickly recalibrating how seriously to take something. To their credit, neither of them simply overpowered me or had me physically removed in that instant, which they absolutely had the authority and justification to do at that point. Instead, Dr. Reyes asked Carol whether an updated set of vitals had been taken in the last several minutes. Carol said no, the last set was from over 30 minutes earlier. Before the hallway conversation began, Dr. Reyes said, somewhat sharply, that if this was going to become a full stop of a scheduled case, he wanted current numbers before anyone made another decision, and he wanted them now. A tech rushed over with a portable monitor. I remember the sound of the cuff inflating, that mechanical hiss, feeling impossibly loud in a hallway that had gone almost silent except for Walter, still lying on the gurney between us, looking increasingly frightened, not by any pain he was feeling, but by the sight of 3 surgeons and 2 nurses arguing intensely with him as the unwilling centerpiece of it all. He asked in a small voice if everything was okay, and nobody answered him right away, which I think frightened him more than an honest answer would have. Standing there waiting for the cuff to cycle, I noticed details I had no business noticing, the kind of details your mind grabs onto when it needs somewhere to put itself so it does not spiral. The overhead light directly above us had a faint flicker in it, barely perceptible, on maybe every 4th cycle. Someone down the hall had left a supply cart with one wheel angled wrong, so it sat crooked against the wall like it had been abandoned mid-thought. I could hear, faintly, the hum of the ventilation system, and underneath that, the specific squeak of Dr. Reyes shifting his weight in his surgical shoe covers, back and forth, back and forth. A nervous habit I would not have expected from a man who had probably performed thousands of procedures in his career. Even experienced hands get restless when a patient is lying in front of them and nobody yet knows what is true. My own hands, I realized, were shaking slightly, and I pressed them flat against my thighs to still them, not wanting Walter to see and read something into it that would frighten him further. My mouth had gone dry in a way that had nothing to do with the recycled hospital air. I kept running the shape of that pulsing sensation over and over in my mind, trying to decide if I was remembering it accurately or if fear and adrenaline were reshaping the memory into something more alarming than it had actually felt under my fingers. That uncertainty was, I think, the worst part of the entire morning, not the fear of being wrong in front of everyone, the fear of not being able to trust my own memory of the one piece of evidence I actually had. The new reading came back, and this time the blood pressure gap between his arms had widened again, worse than the very first reading I had taken that morning, and his pulse had climbed higher than it had been at any point that day. Dr. Webb looked at the numbers, and I watched 22 years of clinical instinct visibly recalculate in real time behind his eyes. He was not a stubborn man. He was a careful one, and careful people update when the data updates. He asked Carol to page vascular surgery immediately and told the OR staff to hold the room, and for the first time since I had stepped in front of that gurney, nobody was telling me to move. But holding the room and canceling the room were not the same thing, and Dr. Webb still had not fully committed to believing what I believed. He said, reasonably, that a rising blood pressure gap under stress could also simply reflect anxiety, that a frightened man lying on a gurney surrounded by an escalating argument would naturally show elevated and asymmetric readings that meant nothing at all about his aorta. It was, again, a completely rational explanation. Fear does change vitals. He was not wrong that this was possible. He said he wanted one more assessment, an ultrasound if it could be brought bedside quickly, before he would agree to fully cancel a surgery this many minutes into pre-op with an OR team already standing by and a patient already prepped. Someone went to find a portable ultrasound machine. The seconds after that felt longer than any other part of that entire day. Walter reached out and took my hand at one point, his grip surprisingly strong, stronger than I expected from a man who had spent the last hour being poked, prodded, and argued over, and asked me quietly if he was going to be all right. I remember not knowing, in the most literal sense, what to tell him. I did not have a diagnosis. I had a feeling under my fingers and a set of numbers that would not sit still in a room full of experienced, reasonable people who were, even now, only half convinced. I told him the truth, that I did not know yet, but that everyone in that hallway was taking him seriously, and that I was not going anywhere until we did know. He nodded, and his eyes went glassy for a second, and he squeezed my hand a little tighter. Carol's radio crackled again, and this time it connected through to the front desk, and I heard, faint but unmistakable, someone confirming that security had indeed been dispatched a few minutes earlier and were currently en route to our floor. I felt my stomach drop in a way that had nothing to do with Walter. For one disorienting second, I had almost forgotten that part of the morning entirely, that somewhere in the building, 2 officers were walking toward us with the understanding that a nurse had lost control of herself and needed to be physically removed from a hallway. Nobody had called to stand them down yet. Everyone in that hallway was too focused on Walter to remember that detail. Everyone except me. Then, from down the hallway, I heard the radio crackle a second time, this one connecting to vascular surgery instead, and a voice came through asking for a quick summary of what they were being called in for. Carol began repeating everything I had told her, the pulsing, the location, the widening blood pressure gap, and as she spoke, I watched Dr. Webb glance toward the ultrasound machine being wheeled down the hall toward us, still a good 20 feet away, and then glance back at Walter, whose face had gone pale in a way it had not been even a few minutes earlier. And that was the moment the monitor on the portable unit beside him began beeping in a rhythm none of us wanted to hear. The sound was not the flat, panicked alarm you hear in movies. It was a specific, irregular pattern, a rhythm that skipped and stuttered instead of holding steady, the kind of sound that makes every trained person in a hallway go still for half a second before moving all at once. Dr. Reyes was the first to react, stepping directly to the monitor and reading the numbers aloud, and I heard his voice change, the calm authority of a few minutes earlier, replaced by something sharper and faster. Walter's oxygen saturation had dropped several points in under a minute, and his heart rate had climbed past 110, and his blood pressure, when the machine finished its cycle, showed a gap between his arms, wider than anything I had recorded that entire morning. Dr. Webb did not hesitate this time. He told the tech to get the ultrasound to the bedside immediately, forget wheeling it the rest of the way, physically carry the probe over if that was faster, and within seconds, someone had the gel on Walter's abdomen, and the probe pressed against his skin, angled toward the space just left of his spine where I had first felt that strange pulsing sensation. The small black and white screen flickered to life, and I watched 3 surgeons lean in at once, their earlier skepticism gone entirely, replaced by the focused silence of people looking at something they had not expected to see. I could not read the screen myself with any real medical fluency, but I did not need to. I watched Dr. Webb's jaw tighten. I watched Dr. Reyes exhale slowly through his nose, the way people do when a private fear becomes a confirmed fact. The third surgeon, a quieter man named Dr. Alvarez, who had been standing slightly apart from the argument for most of it, said one word, low, almost to himself, and it was a word I recognized from nursing school, even though I had never heard it spoken, with that particular weight of urgency before. Aneurysm, specifically, and I would only fully understand the details later that afternoon after several people explained it to me more than once. An abdominal aortic aneurysm, a weakened, ballooning section of the body's largest blood vessel, sitting directly along the path any surgical positioning for a knee replacement would have required, in a location where the added pressure of general anesthesia, the specific positioning on the operating table, and even the simple act of being moved onto that table could have been enough to cause it to rupture. Dr. Webb straightened up from the screen and looked at me for a long moment before he said anything to anyone else. I do not think I will ever forget that particular look. Not triumphant on my behalf, not apologetic exactly either, but something closer to recalibration. The look of a man updating 22 years of pattern recognition in real time because a pattern he trusted had just failed to predict something a 19-day nurse had caught with her fingers and the blood pressure cuff. He did not say anything to me in that moment. There was no time for it. He turned immediately to the team and began giving rapid instructions, canceling the knee replacement entirely, calling for an emergency vascular surgery consult to review the imaging properly, ordering a CT angiogram to get a clearer picture of the aneurysm's exact size and shape before anyone decided what came next. The next 20 minutes moved faster than almost anything I had experienced in my short time as a nurse. Walter was wheeled, still on the same gurney I had blocked with my own body only a short while earlier, toward imaging instead of toward the operating room. I walked alongside him for as long as I was allowed, and he reached for my hand again, and this time his voice was shaking in a way that had nothing to do with performance or politeness. He asked me very quietly if I had somehow known, and I told him honestly that I had not known, not really, not in the way he meant. I told him I had noticed something that did not add up, and that not adding up was different from knowing, and that the not knowing had been the hardest part of the entire morning for me too. The CT scan confirmed what the bedside ultrasound had already suggested. The aneurysm was significant, larger than the kind of finding that gets monitored and revisited at a future appointment, sitting in a location and at a size that vascular surgery classified as requiring intervention soon, though not necessarily within the hour the way the earlier signs of distress had briefly suggested. Walter's vitals stabilized once he was no longer lying flat on an operating table with a knee procedure ahead of him, and once the immediate stress of the hallway confrontation had passed. The team explained to him, in the calm and thorough way medical teams explain serious things once the crisis moment has passed, that the aneurysm needed to be addressed before any elective procedure like the knee replacement could safely happen, and that had he gone into that operating room as originally scheduled, the positioning required for the surgery, combined with the blood pressure changes that general anesthesia typically causes, carried a meaningful risk of causing the aneurysm to tear. I was not in the room for most of these conversations. Once Walter was safely in the hands of the vascular team, my actual involvement in his case was largely finished, which is a strange thing to sit with when you have just spent an hour of your life convinced you were the only thing standing between a man and a catastrophe. I went back to the surgical floor to finish the rest of my shift because other patients still needed vitals taken and medications administered and questions answered, and the hospital does not pause simply because one story inside it reached a dramatic turning point. But word travels fast on a floor like that, faster than I expected, and by early afternoon I had been pulled aside twice by nurses I barely knew, asking if I was the one who had blocked the OR doors that morning. I did not know how to answer those questions yet, because I still did not fully understand how the morning would be remembered, whether I would be seen as the nurse who caught something real or the nurse who had caused an unnecessary scene that happened, by luck, to align with a genuine finding. The difference between those two versions of the story felt enormous to me, and I had no control over which one would stick. Carol found me around 2 in the afternoon in the small break room where I was eating a sandwich I did not particularly want, mostly because my hands needed something to do. She sat down across from me without saying anything for a moment, and I remember bracing myself, unsure whether I was about to be reprimanded or reassured. She told me that Dr. Webb had already spoken with the unit director about what happened, and that a formal review of the incident would be conducted. Standard procedure, any time a scheduled surgery is halted the way this one had been, especially given how it had started with a nurse physically blocking the entrance, rather than the case simply being called off through normal channels. I asked her, probably more anxiously than I intended, whether that review was likely to go badly for me. Carol considered the question honestly instead of offering an easy reassurance, which I appreciated even as it made my stomach twist. She said that, in a strict procedural sense, what I had done that morning, physically blocking a gurney after a physician had already made and communicated his decision, was a real violation, the kind that in a different outcome, a false alarm, an aneurysm that turned out not to be there, could reasonably have led to serious disciplinary consequences, possibly even termination, because hospitals cannot function if staff members are permitted to override physician decisions through physical obstruction whenever they feel strongly enough about something. But she also said, and this is the part I held onto for the rest of that day, that outcomes matter in medicine in ways that policy manuals do not always capture cleanly, and that a nurse whose instinct had just been vindicated by an actual, visible, life-threatening finding was a very different conversation for a review committee than a nurse whose instinct had been wrong. She was careful not to promise me anything. She said the review process still had to happen, still had to be taken seriously, regardless of the outcome, because the precedent of a nurse blocking a doorway could not simply be waved away by good luck. And I understood and respected that even as I sat there, feeling the full weight of 19 days of employment, hanging in a kind of suspended uncertainty, I want to be honest about something else, because I think it matters for anyone watching this who has been in a similar position. In the hours after Walter was moved to the vascular unit, I did not feel triumphant. I did not feel vindicated in the dramatic way you might expect from watching a movie about a moment like this. Mostly, I felt exhausted and a little sick, replaying every version of the morning where I had let Carol guide me out of the way, where I had accepted Dr. Webb's first explanation and stepped back, where the surgery had proceeded as scheduled, and something had gone catastrophically wrong 40 minutes into a routine knee replacement, in front of a full operating room that had no reason to expect it. That thought, more than any sense of having been right, was the one that stayed with me the longest that day. The formal review happened 4 days later, on a Tuesday, in a small conference room on the administrative floor that I had never once set foot in during my first 19 days at Trinity. I sat at one end of a long table across from the unit director, a representative from nursing administration, and Carol, who was there partly as a witness, and partly, I think, as someone advocating quietly on my behalf without ever overstepping the formality of the process. Dr. Webb was not required to attend, but he came anyway, still in his white coat, having apparently stepped out of a gap between 2 other procedures to be there. I want to describe what that meeting actually felt like, because I think people imagine these moments as either total vindication or total punishment, and the truth was much quieter than either of those. The director began by reading through the timeline of that morning almost clinically, the initial vitals, the resident's assessment, the attending's assessment, the moment I stepped in front of the gurney, the ultrasound, the CT confirmation. He asked me to walk through my reasoning at each stage, not accusingly, but the way you would ask someone to explain a decision that had turned out to matter, wanting to understand the actual thought process rather than simply the outcome. I told him honestly that I had not been certain of anything specific at any point that morning, not the blood pressure discrepancy, not the pulse difference, not even the moment I felt that strange pulsing near his spine. I told him that what I had was a collection of small things that individually meant very little and together would not leave me alone, and that I had tried at every stage to escalate through the proper channels first, to Dr. Patel, then to Carol, then to Dr. Webb himself, and that blocking the gurney had only happened after all of those channels had been exhausted, and I still could not make the feeling go away. Dr. Webb spoke next, and this is the part I have replayed in my mind more than almost anything else from that entire week. He did not frame what happened as him being wrong and me being right, which I appreciated more than I expected to, because I never wanted this to become a story where an experienced surgeon looked foolish. Instead, he described, in careful, measured language, exactly what I described earlier in this story, that every decision he made that morning had been reasonable, given the information available at each stage, that a blood pressure discrepancy that narrows on a repeat reading, a mild pulse difference in an older patient, and vague back soreness genuinely did not meet the threshold for canceling a scheduled surgery under normal circumstances, and that any surgeon in his position, working from that same information, would very likely have made the same calls he did. What he said next was the part that mattered most. He said that medicine operates on probabilities and patterns built from thousands of cases, and that those patterns are usually right, which is exactly why they are trusted. But he said that patterns, by their nature, are built to predict the common outcome, not the rare one, and that the rare outcome does not announce itself clearly enough for a pattern to catch it every time. He said that what changed the outcome that morning was not a superior form of medical knowledge on my part, but simply that I was standing close enough, paying attention closely enough, and stubborn enough not to let a feeling go unexamined even after 3 reasonable authorities had told me, with good reason, that it likely meant nothing. The director asked him directly what disciplinary outcome he would recommend, given the policy violation involved in physically obstructing a scheduled procedure. Dr. Webb said, without much hesitation, that he did not believe termination or any serious disciplinary action was appropriate in this case, that the review process itself and my willingness to sit through it honestly was sufficient acknowledgement of the seriousness of what had happened, and that, in his professional opinion, punishing a nurse severely for an action that had directly prevented a life-threatening complication would send exactly the wrong message to every other nurse on that floor about whether their observations were worth pursuing when the stakes felt high enough. I was not cleared of everything, and I want to be honest about that too, because I think it matters for the truth of the story rather than the drama of it. I received a formal written note in my file acknowledging that I had violated procedure by physically obstructing a patient transport after a physician's decision had already been made, and I was required to complete an additional training module on escalation protocols, which, honestly, felt fair to me. The note also included, at Dr. Webb's specific request, a summary of the clinical outcome and his own assessment that my underlying observations had been sound and appropriately escalated at every step prior to the final physical intervention. Carol told me afterward, once we were back out in the hallway and the tightness in my chest had finally started to loosen, that this was about as good an outcome as anyone in my position could reasonably have hoped for. Not a clean slate, not a medal, but an honest acknowledgement on paper that both things were true at once, that I had broken a real rule, and that breaking it had mattered in exactly the way it needed to. Walter went into vascular surgery 6 days later, once his aneurysm had been fully evaluated and the surgical team had a clear plan in place. The procedure went smoothly, and he recovered well, though his knee replacement was delayed by several months while his body healed from the more urgent surgery first. I visited him twice during his recovery, not officially, just stopping by on my breaks, and the second time, he was sitting up in bed working through a crossword puzzle, looking more like the man who had joked about embarrassing himself under anesthesia than the frightened man who had gripped my hand in that hallway. He told me on that second visit that his daughter had done some research after everything happened and found out that ruptured abdominal aortic aneurysms are fatal in a significant majority of cases when they occur outside a hospital, and fatal in a meaningful percentage even when they occur inside one, depending on how quickly they are caught. He did not say this dramatically. He said it quietly, almost matter of fact, the way people talk about things that are too large to hold on to directly for very long. Then he asked me, half joking, if I planned on making a habit of interrupting surgeries, and I told him I sincerely hoped not, that once in a career felt like plenty. I think about that morning often, more than I expected to, when it was actually happening. I think about how close the entire outcome came to going a different way, not because anyone involved was careless, but because the whole structure of how decisions get made in a hospital, sensibly, is built to trust experience and probability over an unprovable feeling from someone with 19 days on the floor. I think about how easily I could have let Carol guide me out of that hallway, how reasonable that choice would have looked from every angle, and how nobody, not one person, would have blamed me for it. What stays with me most, though, is not the moment the ultrasound screen lit up, or the beeping monitor, or even the relief of watching Walter recover. It is the specific look on Dr. Webb's face in that review meeting, when he chose to describe what happened not as him being wrong, but as the natural limit of even excellent judgment, meeting a rare exception, and his willingness to say plainly, in front of the people who controlled my future at that hospital, that the exception had mattered, and that I had been the one paying close enough attention to catch it. 19 days had felt, that morning, like nothing at all to risk everything over. Looking back now, I think they were exactly enough. If you have made it this far, thank you for sitting through this one with me. If any part of it reminded you of a moment in your own life where you noticed something nobody else could see yet, I would genuinely love to hear about it below. And if you want more stories like this one, ordinary people who paid a real price for trusting what they knew before anyone else believed them, I put up a new one every week. So consider sticking around for the next one.